Hello and welcome. My name is Joe Caramelli. I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. Thank you for joining today's Grand Rounds presentation. I want to go over a few points about Grand Rounds. First, for this academic year, we're trying to have presentations consistent with this theme we're calling Next Steps in Care. And I think for today, Next Steps in Care related to perinatal psychiatry, clinical decisions, and models of care. There's a group of us, a core group of us who work on Grand Rounds each week, which includes Semhar Abraha doing communications and coordination, and Mike Walker on technology. We archive all of our presentations on the Grand Rounds website, and you can view presentations that have occurred earlier in the year. You can submit questions today throughout the presentation, which I'll consolidate and go through with Dr. Bott at the end. By typing them in the comments area. After the presentation, please complete the brief evaluation, which I'll put into the chat area during the presentation as well. And I'd like to acknowledge the Ripley Fund as funding for the series and the institutes in the department, such as the Garvey Institute for Brain Health Solutions. Now for today. Today's presenter is Dr. Amrita Bott. And very briefly on background, Dr. Bott trained initially at St. John's Medical College Hospital in Bangalore, and later moved to Seattle and trained in the psychiatry residency program at UW, and then completed research-specific training in an NIMH-funded primary care psychiatry fellowship. And during that fellowship, completed a master's in public health. And since then, Dr. Bott has worked as a faculty member focusing specifically on perinatal psychiatry. And now, when we think about perinatal psychiatry, often what comes to mind might include reasoning through a specific treatment decision, such as treatment in a pregnant woman diagnosed with bipolar disorder, or evaluating incident symptoms subsequent to delivery in the postpartum period, for example. Dr. Bott does this and is a clinical expert in perinatal psychiatry, having worked in several UW Medical Center clinics doing perinatal psychiatry specifically for over 7 years. But beyond the clinical practice, what makes Dr. Bott distinct is viewing perinatal psychiatry more broadly. Where is care delivered during pregnancy? How is it delivered? What are ways to match clinical services to the clinical epidemiology? And even beyond that, after delivery, what is parenting like? How are parent-child relationships and outcomes influenced by treatable psychiatric disorders? And how might parenting skills training help? And in each of these areas, Dr. Bott is active clinically and has active research programs, including being principal investigator on an R-level grant from NIMH called the Dyadic Approach to Perinatal Depression Treatment in Primary Care. Additionally, Dr. Bott is site PI for a large United States-wide comparative effectiveness study evaluating the Perinatal Psychiatry Access Program. I'll stop there and I'll turn it over to Dr. Bott, and we'll go through questions at the end. Thank you, Dr. Bott.
Thank you for that introduction, and thank you so much for this opportunity to present. Let me start sharing my screen here. Great. So I'm going to start us off with a quiz. Here is a depiction of the average number of psychiatric hospitalizations per month in a cohort of about 55,000 people over a period of 2 years before and 2 years after a major life event. And the question is, guess what life event this is? This is probably an unfair quiz because you can't really call out the answer. And of course, the title of this talk is a big giveaway. But if you guessed childbirth, you guessed right. As you can see, right after childbirth, there's about a 7-time increase in the average number of psychiatric hospitalizations. And that risk stays elevated for up to 2 years after delivery. So in terms of major life events that can precipitate psychiatric disorders, no event is as predictable as childbirth with a very specific expected date of delivery or date of delivery. And in fact, women are more likely to experience major depression and more likely to be psychiatrically hospitalized in the year following childbirth than at any other point in their lives. And this might be why traditionally there's several rituals that happen in this period that are thought of as preventive and protective. They might be things like doing the month, meal trains, baby showers, increased social support for those who are lucky to have it. And I would argue that the healthcare system can also think about prevention, especially because in addition to having a predictable time point, we also know that there are several factors that can identify those at higher risk for these psychiatric disorders in the postpartum period. So these risk factors include things like past history of depression, current depressive symptoms, being an adolescent or single parent, having experienced recent intimate partner violence, elevated anxiety, and adverse life events. The good thing is there are multiple opportunities in the perinatal period, which is the period from conception through 1 year postpartum, to actually detect the people who have these risk factors. So for those engaged with the healthcare system, there are about 10 to 12 antenatal visits in the year before, in the 9 months before delivery, and 1 to 2 postpartum visits for the parent, and 6 to 8 well-child visits for the child in the year following childbirth. For parents whose babies are in the NICU, that's an interaction with the healthcare system as well. So I will discuss why we need to improve access to perinatal mental health care, including prevention and treatment, and how we go about doing that. We already talked about the fact that the structure of perinatal and postpartum healthcare allows multiple opportunities to identify and treat these disorders. So let's talk about prevalence and impact for a little bit. These are the rates of perinatal depression, anxiety, PTSD, and postpartum psychosis. As you can see, they range from the low 0.1% for the severe disorder postpartum psychosis to as high as 20% for the more common mental disorders. And these look at the prevalence of these disorders through pregnancy and the 1 year postpartum. These rates might be higher in low resource settings and in communities that are marginalized by the healthcare system. Now let's compare this to the prevalence of disorders which are considered common in pregnancy. Oops. So any hypertension in pregnancy, the prevalence of that is 8.6%. That includes pregnancy-induced hypertension and chronic hypertension, and gestational diabetes is 7%. And we know that for someone getting regular prenatal care, their blood pressure gets measured at every prenatal visit. Every pregnant individual gets a glucose tolerance test. But we are only just beginning to think about universal screening for the more common perinatal depression and anxiety. And how are we doing identifying and treating these common disorders? Unfortunately, not so well. So of all of the people with perinatal depression, about half of them get detected to have these disorders. 15% get any treatment. And by any treatment, the study looked at even 1 dose of an antidepressant or 1 session of psychotherapy. 7% get adequate treatment, but only 4% are treated to remission. So you can see here that patients fall through the cracks at every stage from detection to remission. And it's true that this pattern of the treatment gap or patients falling through the cracks is true of mental health treatment in all populations, but there seems to be something specific about pregnancy that magnifies this effect. So if you look at the study, which compared pregnant women with a matched cohort of women who are not pregnant, they tried to calculate how many women with depression did not get treatment and how many women reported an unmet mental health need. And this cohort, 51% of pregnant women who had depression did not get treatment, as compared to 43% of non-pregnant women. And 40% of pregnant women reported having an unmet need for mental health care, treatment or counseling, compared to 34% of the non-pregnant women. And there's more than what I've shown in this graph. Women who are already on antidepressants tend to discontinue those medications when pregnant and not restart at postpartum. And while in some cases this might be appropriate or necessary, in most cases, we know that this practice of stopping medications increases the risk of relapse of depression in pregnancy or postpartum. And we don't know for sure why this might be, that the treatment gap is so magnified in the perinatal period. but it's possibly a combination of factors, including provider bias. You know, there's this myth about the pregnancy glow. It's a great time in your life and you're supposed to be happy. There might also be liability issues where clinicians are uncomfortable prescribing medications because of concern for fetal harm. And stigma seems to be magnified in this population as well. What happens when we leave perinatal mental health disorders untreated? Several negative impacts. Individuals who have perinatal mental health disorders and perinatal substance use disorders are less likely to engage in prenatal care. They are more likely to have increased rates of substance use and smoking, higher rates of pregnancy complications like preeclampsia, higher rates of gestational weight retention, lactational difficulties, and it's costly to leave these disorders untreated. For a 5-year cohort from 2017, where they looked at the accumulated costs for a mother-baby dyad, where the mother had untreated depression, they found that it costs $14 billion. And this included lost economic productivity among the affected mothers, more preterm births, and other maternal health expenditures. More recently, we are beginning to learn that as we have gotten a better handle on pregnancy, other pregnancy complications like preeclampsia and postpartum hemorrhage, mental health conditions like depression and substance use disorder with the associated risk for suicide and overdose are now the leading cause of maternal mortality. And if you look at this graph of the leading causes of pregnancy-related death, especially focusing on preventable deaths, you can see that mental health conditions rank higher than things like hemorrhage and preeclampsia. And this is a study from 14 US states. The impact extends beyond the affected parent. It extends intergenerationally. So we know that children of mothers with perinatal depression are more likely to be born preterm, to have low birth weight. They have increased rates of dysregulation, irritability, crying, sleep difficulties, malnutrition, stunted growth, higher rates of hospitalization and mortality in the first year, higher rates of cognitive, emotional, and developmental delays, more likely to have a difficult temperament or slow to warm up temperament, higher rates of internalizing disorders like anxiety and depression, and externalizing disorders like ADHD and conduct disorder in childhood. And they are at a higher risk for depression all the way through adolescence. And this is even when you account for the genetic factors of the heritability of depression. All of these impacts are worse with current depression based on the studies that have looked at this, but there also seem to be lingering effects with past depression, and chronic or severe depression has the most impact. There are effects on the families as well. There are adverse effects on the partner's mood, increased rates of discord, and impaired family functioning. So what do we know about how this risk gets transmitted from the birthing parent to the next generation, to the child? We're learning more about this more recently. There is, of course, the non-modifiable genetic factor. So the heritability of depression is about 20 to 40%, depending on whether one or both parents are affected. But also, the first environment that a human being experiences is inside the mother's womb. And this environment can have a big impact on the development of the fetus. So this is called the fetal programming hypothesis, which states that while there are periods of rapid development, the fetus is very susceptible to environmental influences, and the effects of these environmental influences can persist across the lifetime. An example which is frequently cited to describe this fetal programming hypothesis is that of the Dutch famine. In 1944 to 45, there was a cohort of women who suffered from extreme malnutrition while they were pregnant. And these women had smaller babies. The babies were born lower birth weight, but when they followed these babies through the years, they found out that they grew up to have higher rates of diabetes, obesity, and cardiovascular disease. And the stress that can cause these changes includes not only poor nutrition, but also poverty, traumatic stressors, natural disasters, and relevant to this talk, maternal psychological distress and psychiatric disorders. The mechanism for this fetal programming is still being figured out, but two of the main hypotheses are that it works through changes in the infant's hypothalamo-pituitary adrenal axis by exposure to maternal cortisol, or through epigenetic changes. The third important mechanism of transmission of intergenerational risk is the fact that an infant's social and emotional development is shaped dynamically throughout the first year of life and beyond, but mostly during the first year of life as a result of the interactions between the infant and the caregiver. So I'll share this video.
What the mother did was she sits down and she's playing with her baby who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, you.
Okay, so that was a somewhat exaggerated description of or depiction of how these interactions go. But as you could see from that, mental illness in parents in the first postpartum year has the potential to change a parent's attention, their sensitivity, and combine this with the fact that babies that are exposed in utero to depression and anxiety are already more likely to have higher rates of dysregulation and higher rates of sleep difficulties. So you can see how this can make for suboptimal interactions, leading to poor attachment and poor bonding, which we know are risk factors for the development of psychopathology in the future. But the good news is that we also know that a sensitive and attentive caregiver can buffer the effects of stress, whether that stress was in utero or postpartum. So this is the second aspect of prevention in perinatal psychiatry, and that is that reducing exposure in utero to maternal or gestational parents' distress while providing parenting interventions may prevent psychopathology in the next generation. In fact, in utero is the earliest point in an individual's lifetime in which we can intervene to prevent negative mental health outcomes. So I hope I've convinced everyone of the need to try and reach and support everyone with a perinatal mental health or substance use problem. And before I move on to talking about how to do that, I wanted to spend some time summarizing what we know about the glaring disparities that exist in treatment access. Because before we make efforts to improve access, we also need to make sure that any of our efforts center the needs of those who are most impacted and those with the most barriers. So we know that the rates of perinatal depression are almost double among people of color, including non-Hispanic, Black, and Hispanic people. We know that African American, Asian, and Native American and multiracial women are less likely to be screened postpartum than white women. And we see similar patterns of care for Medicaid and Medicare versus commercial insurance. There are higher rates of treatment discontinuation among Black women. And among those who initiate antidepressant treatment, there are more likely to be fewer refills among Black women and Latinas. Asian and Native Hawaiian and other Pacific Islander women with depressive symptoms are significantly less likely to receive mental health and substance use services. And women who are living in poverty are less likely to seek mental health consultations. There are, unfortunately, inadequate studies of perinatal health service utilization rates and patterns among sexual minorities. So you might have noticed my use of the term women and maternal mostly, because that is what the published literature is about. But transgender men and non-binary individuals can also get pregnant and give birth, and we need more studies looking at what kind of access barriers they face and how we address those. All of these disparities, of course, have been made many-fold worse because of the COVID-19 pandemic. So moving on to how to improve access to prevention and treatment of perinatal mental health and substance use disorders. Reaching everyone and plugging all those leaks in the pathway to mental health treatment means that we need to use a variety of approaches, and we need to take the care to where they are. And I borrowed this pyramid from the AIM Center. Many of you might be familiar with this, but these are the various approaches that we can take to make sure that we're increasing access to all individuals with perinatal mental health and substance use disorder problems. So at the bottom of that pyramid, arguably the approach with the most reach is workforce development. And one example of workforce development that I will describe is our Moms Access Project, ECHO. Next up there is consultation, or provider-to-provider consultation, and I'll briefly talk about our PAL for Moms consultation line. Then there is integrated perinatal mental health, such as perinatal collaborative care and specialty mental health. And I want to highlight that these approaches are applicable to all populations. It may be that we have more opportunities to reach individuals in the perinatal period. So starting with our Moms Access Project, ECHO, which is a great way to enhance workforce development in this area and increase the capacity and confidence of frontline providers like obstetric providers and pediatric providers to care for their patients with common mental disorders. You can see pictured here our merry band of panelists and staff for the ongoing cohort of our MAP ECHO. Project ECHO is probably the best known example of technology-enabled learning, and it's been implemented widely. Our Project ECHO, our third season, is focused on perinatal mental health and substance use and the intersection of the two. We have a multidisciplinary panel, and we have multidisciplinary participants, which makes for a very rich and interactive learning experience. So for example, the provider types that participate in our ECHO include nurse practitioners, physicians, midwives, social workers, nurses, therapists, and many others. And it is challenging to measure patient outcomes from an ECHO program because these are not our patients. We are hoping that the things we discuss in an ECHO session then lead to changes in practice among our participants when they are caring for their perinatal patients. And so our evaluation to date has included asking about participants' satisfaction, knowledge increase, and competence. And we have tried to tailor this ECHO so that we are reaching across Washington state, especially in counties which have lower access to perinatal mental health treatments, and for participants who serve patients insured by Medicaid. So here's an example of an evaluation we did. This was done at the end of our first season of ECHO in 2019 to 20. We did an exit survey among our participants. And as you can see here, they all noted satisfaction with the ECHO program. They also noted that being a part of the ECHO program helped them increase their access to consultation and their feelings of professional connection. Most of them agreed that the care that they provided to their patients changed because of their participation in this program. And most of them also reported that they used information learned in this program while treating a patient. They all described the program as welcoming and supportive, and felt that their competence and confidence increased. In addition to this survey, we also conducted individual interviews among 9 of the participants to try and get a better sense of what they got out of the ECHO experience. And from their responses, we were able to categorize them into 3 different kinds of participants. One that had no previous exposure to perinatal mental health patient care prior to this ECHO, one that had some exposure, and then one group of participants who had extensive prior experience. And as you can see depicted in the slide here, the first set of participants who had no previous exposure reported increased comfort with screening for depression and anxiety, so the common mental disorders, and initiating a first-line medication while patients waited for referral to a perinatal mental health specialist. The second group, who were somewhat familiar with perinatal mental health treatments, said that they gained new knowledge about previously unfamiliar diagnoses, and they had increased confidence in their ability to manage more common conditions. And the third group of participants who had extensive prior experience primarily reported that they gained reassurance about their approach to patient management. So we surmised that participating in the ECHO allowed these providers to advance along the pathway of medical competence, and how much they applied the information they learned in ECHO was dependent on their pre-participation familiarity and exposure to perinatal mental health issues. And as I mentioned earlier, the ECHO is a very collaborative learning experience, so it is really good to have participants with differing prior experiences. Not depicted on the slide, but I think an important learning we had is that when we think about system-level changes like clinic-wide screening practices, screening for perinatal depression or anxiety, that is difficult to do with just one person from that organization represented in the ECHO. So this is something that we learned, that we need buy-in from their colleagues or from leadership if we need to make system-level or system-wide changes. Okay, moving on to that second level in that pyramid, which is provider-to-provider consultation, or our PAL for Moms line. Perinatal psychiatry access programs such as our PAL for Moms line are common now across the United States. There are about 21 programs funded variously federally or by states or philanthropy, and inspired by similar lines meant for pediatricians. Our PAL for Moms, or perinatal psychiatry consultation program, is available for any provider across Washington state that wants to call us between 9 and 5 on weekdays and has a question about the treatment of their patient who is pregnant or postpartum or struggling with infertility or perinatal loss. Now, the evidence for perinatal psychiatry programs is evolving and emerging. For example, the program in Massachusetts, McPap for Moms, and the program in Wisconsin, Periscope, has published information on the feasibility and acceptability of these programs. We are currently engaged in a multi-site study looking at the comparative effectiveness of perinatal psychiatry access programs on treatment engagement, in which we are looking at access programs with different levels of services provided in the states of New Jersey, Massachusetts, and Washington. And using our PAL for Moms, our perinatal psychiatry consultation line data, we also did a content analysis where we looked at the calls we have received since the inception of the program, and we coded the complexity of the calls as 1, 2, or 3 in increasing complexity. And as you can see here, the complexity of calls that we have been fielding has increased over time. And this has been the experience of us consultants on the line as well, that earlier during our period of operation, most of the calls would be about how to screen for or manage depression and anxiety. But more recently, we have been receiving calls about far more complex patient presentations. And so this might reflect the fact that frontline providers are taking more of an active role in managing their patients' common mental disorders and reaching out for our help when they're dealing with more complexity. Okay. Transitioning on to that next year of integrated perinatal mental health or perinatal collaborative care. So many of us are familiar with this model of care, which, University of Washington is the birthplace of collaborative care, led by studies by Wayne Caton and Jürgen Unutzer. This is a team-based model of care. The team, in the case of perinatal collaborative care, consists of the patient, the primary care provider or obstetric provider, the care manager, and the psychiatric consultant. And the team provides patient-centered care using evidence-based treatments and measurement-based treatment to target. This is a study of perinatal collaborative care in federally qualified health centers in King County. The study was called Mom Care, and it was led by Nancy Grote, who was a wonderful mentor and collaborator that we lost to cancer in December last year. You can see from this graph that compared to maternity support services, or MSS, which was used as the control condition, Mom Care, or perinatal collaborative care, performed better than MSS. In this case, in this graph, you see the remission rates, but also in depression score reduction over time. Mom Care performed better. We also, in a secondary analysis of this data, we looked specifically at women who experienced adverse birth events like preterm birth and low birth weight. We know that these women who have adverse birth events are at a higher risk for postpartum depression. And you can see here that perinatal collaborative care reduced the depression score in these women. So in the top graph is the intervention or Mom Care. And you can see that even the women who had an adverse birth event had lower postpartum depression scores. In the control condition, the women who experienced an adverse birth event had higher depression scores than the women who did not experience an adverse birth event. So it seems to be protective of postpartum depression, even among those who are at higher risk. More recently, we are engaged in a multi-site study of implementation of perinatal collaborative care and using a technique called longitudinal remote consultation or systematic case review consultation, again, which grew out of the work of many years of training and technical assistance by the AIM Center. In LRC, a psychiatrist who has expertise in collaborative care and in perinatal collaborative care joins a clinical team remotely. And this clinical team might be a team that's new to the model. And this LRC psychiatrist regularly joins the local systematic case review meetings to observe and provide feedback to support the implementation of collaborative care and to support the fidelity to collaborative care. And we are just wrapping up a multi-site randomized controlled trial comparing the LRC approach to implementation as usual. So through these studies, we have learned several ways in which perinatal collaborative care is a little different than collaborative care in other populations, or perhaps there are opportunities to do things differently given the structure of perinatal healthcare. This arrow is something that the AIM Center uses to depict the pathway of a patient through the collaborative care process, or the way the clinical team would engage or would establish their workflow. So the first step, of course, is to identify and engage a patient in treatment, then to establish a diagnosis, to initiate treatment, to provide follow-up care, make sure that we're treating to target, and to complete treatment and wellness plan or relapse prevention. So with regard to that first step of identify and engage, again, like I've mentioned before, and we'll probably say it again, there are several opportunities during pregnancy and postpartum and well-child visits to provide a screening for individuals who come in for care. Multiple opportunities to identify people who might need depression, anxiety treatment or other perinatal mental health treatments. There is some, in the perinatal world specifically, there's always discussion around which screening tool to use, whether the PHQ-9 is better or the Edinburgh Postpartum Depression Scale is better, since it's a scale specifically developed for this population. I would say that they're both equally, they have been validated in this population, and using either of them or using the one that you would use most regularly would make the most sense. In terms of establishing a diagnosis, again, this parallels collaborative care in other populations with a few exceptions, like the specific diagnoses of postpartum blues and postpartum psychosis. And these are times in which the team needs to collaborate to make the best diagnosis based on information from the obstetric provider and the care manager, and the discussion with the psychiatric consultant. So postpartum blues are mild but transient depressive symptoms that happen in the first 10 days postpartum and don't require any specific treatment. Postpartum psychosis is a psychiatric emergency seen in 1 in 1,000 deliveries and the patient needs psychiatric hospitalization and may not be able to be managed in a collaborative care approach. When thinking about initiating treatment, the ways in which perinatal collaborative care differs, and we've learned this over the past few trials of perinatal collaborative care, is that psychotherapy approaches sometimes need to be modified. And this is something that we discuss with the care managers or that they receive training in. For example, if you think about cognitive behavior therapy or deep breathing techniques, and someone in their 3rd trimester might not be able to do that. And so we need modifications to that approach. A thing that comes up very frequently is medication safety. So how do we balance the risks of untreated depression that I described earlier, or untreated anxiety, with the risks of medication for the fetus? And how do we make these decisions without having the gold standard information that we get from RCTs? Because no one is going to do an RCT where they compare people on medications during pregnancy for depression to people with depression and not give them medications. The next step of follow-up care and treatment to target, again, repeating it again, multiple opportunities to meet with the individual when they come in for their prenatal care, multiple opportunities for the care manager to meet with them and to engage them. And then the thing that has come up is the safety protocol needs to include not only suicidal ideation, but also a formal or informal assessment of the mother-baby interaction and any concerns for the child's safety. Completing treatment and relapse prevention is where it can sometimes get sticky, because if someone has been getting their collaborative care treatment in the context of their pregnancy care, we know that that's going to end at the 6-week postpartum check with their OB. Although more recently, Medicaid has extended the postpartum coverage to 1 year postpartum. So it's possible that patients might be able to go back to see their OB for longer. But this is the thing that requires modifications and innovative ways of working within the healthcare system that we're still trying to figure out. For example, we know that many pediatricians and pediatric providers are now beginning to screen parents when they bring their children in for well-child visits. And is there a way of connecting between OB and pediatrics and maybe primary care and ensuring that these people who initiated treatment during pregnancy don't end up getting lost in the system? We conducted a pilot study of perinatal collaborative care in Yakima. And in the context of this study, we evaluated the use of text messaging between patients and care managers. And we surveyed the patients and their care managers on their usage of text messaging. And we learned that patients were very responsive to text messages that the care managers initiated at a rate of 86.9%. Patients themselves didn't initiate a whole lot of the messages. Only about 15% of the total messages were initiated by the patients. They really like the asynchronous nature of the text messaging. You know, one of the mothers who participated told me, yeah, if my baby is crying and someone gives me a call, I'm not going to pick up the phone. But if it's a text message, I can always get back to it later. And they also appreciated that they were getting their healthcare needs met in between appointments with their care manager. Here are some graphs of the content of the text messages that the care manager sent and that the patient sent. And you can see that the content of the patient-initiated messages was mostly to get information, to discuss medications, and they would report to their care manager how they were feeling, both their mental and their physical symptoms. So moving on to the next aspect that we have examined in collaborative care studies. So the transition to parenting is arguably one of the most important transitions in a person's life. It can mess with your sleep, it can mess with your schedule. Becoming a parent often updates old conflicts for many people. So Winnicott described this state as a primary maternal preoccupation. And more recently, Brandy Carlisle sang about it as you're tethered to another and you're worried all the time. So one would expect that for someone with depression, parenting would come up frequently as an issue to be addressed. So we wanted to look at this aspect, and in a qualitative study within the pilot collaborative care implementation, we interviewed women who had received collaborative care for depression, and we asked them how their parenting experiences intersected with their depression or their depression care. And these are some of the themes we heard. So the first theme was maternal mood and parenting difficulties are interrelated. So here's a quote. She's talking about her baby. She's had a couple of bouts where she just cries and cries and cries and cries, and I don't know why. And I think it irritates me, and then I feel super bad, and then it would just make me feel even worse about myself. It was just a combination of when she was not doing good, it was, well, what am I doing wrong? Am I just failing at this? So you can see there the themes of guilt, low self-worth or worthlessness, or low parenting self-efficacy, and a feeling of failure. A lot of the depressive symptoms coming through in the context of parenting. The other theme was that access to depression treatment is complicated by expectations for the perinatal period and by factors related to parenting. So here are a few quotes. I didn't want people to say, oh, she's crazy, she's going to harm her baby, or why is she thinking these things if she has everything? And so they would say, be strong, you know, it's your hormones, or you're about to have a baby, aren't you nesting, having fun? It's like, no, I hate life. Women also told us that they wanted parenting support in the context of treatment for perinatal depression. It's that whole, oh crap, it's out of me. What do I do with it now? Where is that manual for the baby? And not only do patients want parenting interventions in the context of depression, we are beginning to learn that it may actually be necessary to provide parenting interventions, especially if we want to improve child outcomes. So there's some meta-analyses which look at randomized controlled trials among pregnant women with depression. And although in these trials, the women's depression was treated to remission, they found no significant effect of the perinatal depression treatment on birth weight, on gestational age, or on APGAR scores. In another study, they found that the effects of perinatal depression treatment on maternal depression was about 0.5, almost an effect size of 0.5, whereas when they looked at the effects on child functioning, the pooled effect size was much lower. So it is this pathway from perinatal mood and anxiety disorders to low maternal or parental sensitivity and low parenting self-efficacy, impaired parent-baby interactions that leads to negative child outcomes. And targeting either the parental distress or dyadic interactions in isolation might not be enough, and interventions targeting both of those, both the parenting distress and the dyadic interaction, might be the best way to reduce the risk of intergenerational transmission. So what are the next steps in perinatal collaborative care? We recently wrapped up a study focused on modifying an evidence-based intervention called Promoting First Relationships, which is a parenting intervention. It's usually delivered as home visits and in the postpartum period. And with funding from the UW Alacrity Center, we worked on receiving feedback from parents with depression and from collaborative care managers in figuring out how do we make it so that we deliver this intervention within the context of collaborative care. So we got feedback from these participants. They felt that the positive things about modifying PFR for delivery during pregnancy and in the primary care or prenatal setting was that it was a great way to provide proactive or preemptive parenting support to these people who need it. And the possible mechanism that increasing someone's self-efficacy or parenting self-efficacy in this case would improve their depression. Some of the challenges they brought up were the lack of demand for parenting support and the session length, which can extend to 45 to 50 minutes, although part of the modification was shortening the intervention. So our next step has been, we are planning to compare collaborative care along with Promoting First Relationships brief to perinatal collaborative care as usual and see how patients do with that. And another step that we would like to take is to use the collaborative care framework to deliver concurrent treatments for perinatal mental health and substance use disorders, because if people with perinatal mental health problems have difficulty accessing care, then that's magnified many times for people with comorbid mental health and substance use disorders. Okay, now we move on to specialty mental health. So we know that even with all of the workforce development efforts, many individuals with perinatal mental health and substance use problems will need a consultation and ongoing care from a specialist. This might be for diagnostic clarification, it might be for informed consent discussions about medications, etc. So in response to the increased need for perinatal mental health treatments during the COVID-19 pandemic, we set up a perinatal telepsychiatry clinic. And we wanted to design this clinic to be very responsive to the well-recognized barriers to addressing mental health treatment. So telepsychiatry would address the logistical barriers such as transportation and needing childcare that a lot of perinatal individuals face. We opened it up so that we enabled direct referrals from prenatal clinics and community-based organizations across Washington state, so they didn't have to wait for a referral from their prenatal or primary care provider. Our outreach was specifically to providers who cared for women with, individuals with barriers to care that we saw earlier that are traditionally marginalized by the healthcare system. We also had the great support from a navigator team that would outreach to the patient after the referral was received, would outreach to the patient at least 3 times and then walk them through the process, which is often a maze of registering and being seen and being scheduled. And then in looking at how we did get referrals for many patients insured by Medicaid. But as you can see here, there is that decrement in care from referral to being scheduled to being seen. And I've used Medicaid and commercial insurance as a proxy here for possible barriers to care. It's an inexact proxy, but it's the best one we had in this data. So we are now thinking about how do we think about other barriers to access and how do we address those barriers. There might be language and cultural barriers. And we know that women individuals who experience lower income or Black, Indigenous, and people of color, they come to care with a set of experiences that makes it challenging for them to trust the healthcare system, and specifically the mental health care system. So we have learned that we need to do much better in tailoring our approaches to reach the most vulnerable people. And then there are specific approaches that have been proven to reduce disparities. We know that collaborative care itself is more effective in low-income populations. Centering pregnancy is a group-based prenatal care that has been shown to decrease preterm birth disparities for African-American women. There are other interventions, including mothers to baby and mom care, that have been shown to address these specific barriers. So to summarize, there's multiple entry points to perinatal mental health care throughout an individual's perinatal journey, and collaborations with the different healthcare systems and different healthcare providers that these perinatal individuals interact with throughout their pregnancy and postpartum is critical if we need to reach all of those who need mental health or substance use disorder treatment. So I've listed here some of the healthcare providers that an individual might encounter, but that may not be enough. So we know that perinatal individuals also interact with other providers like community health workers and doulas, who might actually help bridge the gap between patients and between specialty mental health. They might help to deliver knowledge, they might help to shape a positive attitude. They also help to address the social determinants of health. It might engage the patient's community better to work with the community health worker. And we can learn as psychiatrists or mental health providers, we can learn how to align the care that we provide with the patient's perceived need. So psychiatrists and other mental health providers need to partner with clinicians and with community supports in different roles as a consultant, as an educator, and a psychiatrist. Now, the challenge is that the community support system often runs parallel to the healthcare system, but some early work done with older adults by Jürgen Unitzer and Teresa Heft have shown promising results in bridging this gap between community and clinic. Other countries have also bridged community supports and healthcare systems by integrating mental health into maternal child health, such as nutrition and positive parenting programs in Africa, the very well-known Thinking Healthy program in Pakistan, and child development programs. And we recently completed a systematic review of screening for perinatal depression and anxiety in community-based settings. And we found, on looking at 47 studies of screening for common perinatal mental disorders in community settings, that screening was found to be feasible and acceptable to both the community health provider and the patient. The most frequently used tool was the Edinburgh Postpartum Depression Scale, but none of the studies really described what happened next after a screen. We weren't able to determine in what frequency of screening was ideal, and perinatal depression was focused on more than perinatal anxiety. So next steps in improving perinatal mental health treatment access. Lots of work still to be done to get high quality perinatal mental health care out to where it can be accessed most easily. Other groups are working on randomized controlled trials to look at the mechanisms for intergenerational transmission. And we are excited about partnering with community-based providers like peer support and doula, and using technology like texting and app-based screening to do this. A shout out to our amazing maternal child mental health team, without whom none of this work would have been possible, and my mentors and collaborators. I might not have listed everyone. Funding and references. Thank you.
Well, thank you, Dr. Bhatt. What a view of different intensities of specialty care and ways that you're working clinically and on research studies at different levels of intensity. I'd like to encourage participants to write in with any questions about anything Dr. Bhatt presented on clinical programs, research studies, interpreting results, and so on. One question comes to mind, Dr. Bhatt, as others maybe think about what they want to write in. Is it correct to say that treating depression during pregnancy decreases this in utero stress. Is that an accurate statement? What do you think?
There have been some studies looking at this. They actually look at things like fetal heart rate variability among depressed women who have been treated and who have not. And we do have some signal that it's true that women whose depression is adequately treated, the fetal markers of stress are less likely to be present than women with active depression. Now, it's also confounded by the fact that some of the treatments like medication management can also affect the fetus. So it's a field that's growing very rapidly, and we're learning more each day.
Thank you. And anyone else with a question, please consider writing it in. We've got a couple of minutes to go through questions here with our colleague, Dr. Bhatt. I was just thinking about this during your presentation. I mean, I wonder if a lot of what you encounter is maybe a need to persuade others, clinicians, our colleagues in other fields to take on assessment and treatment, our own colleagues to treat women during pregnancy who may be apprehensive to do so, patients to consider treatment. I mean, is that what it's like? Am I mischaracterizing it?
No, it is a lot of education. It begins with education about the need to screen that, yes, pregnant and postpartum individuals also experience perinatal mental health problems, perhaps at a higher rate. I think, awareness has increased more recently. And so focus can shift a little bit from screening to then treating. And, the more people you screen, the more people need treatment. And there's only so many psychiatrists, let alone perinatal psychiatrists. So it's a lot of, I think, providing support to the frontline providers through all of our education programs and consultation program goes a long way in convincing them to take on the care of people with common mental disorders. And I get it. I wouldn't want to manage pregnancy-induced hypertension on my own with no help. So, and patients as well. You brought up patients. Patients always have a difficult time balancing the risks of untreated mental health problems with the known and unknown risk of medication.
A minute or two left. I invite anyone to write in a question. I wonder, I mean, you showed modifications to considerations for modifications in collaborative care. Very interesting and compelling. Are there psychotherapies that are unique to the pregnancy period? What are they? Do you deliver them?
Well, we have a lot of training in interpersonal therapy here, which has been shown. It's for all populations, but it's been modified for the perinatal populations. Cognitive behavior therapy has been modified for the perinatal populations. And certain psychotherapies, which include attention to the mother, so mother-infant therapy. There's another one called PrEP, which is a group therapy, which includes CBT for depression, but also parenting information. So yes, there are several psychotherapies that are tailored for pregnant individuals.
Okay, well, we've got just a minute left. I think since there's no pending question that's come in, I'll just use it to really emphasize how what a collection of studies, descriptions of next steps in what you want to take on with modifications in collaborative care, other disorders, for example, to take on in evaluation and treatment, and just different ways of talking about the pyramid, as you showed, and focusing on different levels of intensity of specialty care. So thank you, Dr. Bhatt, for presenting today at Grand Rounds. And we could end there for today.
Thank you.